Thank you again for joining us today. My name is Lee Montville, and I'm on the Springer Publishing Company Sales and Business Development team. We are thrilled to offer a special webinar, Trauma, Personal and Public Health Issues with Dr. Lisa Lopez-Levers. Please put any questions that you have in the Q&A box. And at the end of the webinar, my colleague Rhonda Dearborn will ask Dr. Lopez-Levers those questions. And stay tuned for a special offer for Dr. Lopez-Levers' new book, Trauma Counseling, 2nd edition. Please note that this event will be recorded and will be archived so that you'll be able to access it in the future. You will be emailed a recording of the webinar within 7 to 10 business days. And Dr. Lopez-Levers has graciously agreed to share a PDF of the PowerPoint so that you'll be receiving that as well. Today, it is my great pleasure to introduce our speaker, Dr. Lisa Lopez-Levers. Dr. Lisa Lopez-Levers is Professor Emeritus and has held the Endowed Chair in African Studies at Duquesne University in Pittsburgh, Pennsylvania from 2012 to 2017. She served as department chair and program director at other universities. Prior to 32 years of university teaching, she worked in the community mental health sector for 15 years, counseling survivors of trauma. Professor Levers has published books, chapters, and journal articles on trauma and disaster, disability, African culture, and the counseling profession. She recently edited 2 textbooks, Trauma Counseling, Theories and Interventions for Managing Stress, Crisis, Trauma, and Disaster, 2nd edition, published this year by us at Springer Publishing Company, and Clinical Mental Health Counseling, Practicing in Integrated Systems of Care in 2020. Dr. Lopez-Levers has also been awarded numerous grants and awards and was a Fulbright Scholar at the University of Botswana in 2003 and 2004. She works with marginalized communities in developing culturally sensitive systems of care, creating better access to services, designing responses to trauma, and building community resilience. She recently was elected as the president-elect of the International Association for Resilience and Trauma Counseling, which is a new division of the American Counseling Association. So now, without further ado, take it away, Dr. Lopez-Levers.
Hello, everyone. I'm so glad that you all could join us, and thank you, Lee, for that wonderful introduction. So, we tend to think of trauma and its impact in terms of an event that's occurred, something bad that has happened to someone. And it's usually true that something awful has occurred, but the issue of trauma is much more complex than a simple or single event. So in today's webinar, I'd like to dive into the complexity of trauma, first by discussing trauma as an individual issue as well as a public health issue, and then by focusing on the intersections and potential synergy of individual and collective trauma as an issue that we need to address and to consider in our recovery and healing processes. At the end of the webinar, I'm hoping that we're all better able to define trauma from individual and public health perspectives, understand the importance of the systemic implications of trauma, become familiar with recent neurobiological research that is relevant to trauma, and demonstrate an awareness of the intersection of multiple issues that are relevant to trauma treatment. I always like to begin any discussion about trauma with this popularized quote by His Holiness the Dalai Lama. Pain is inevitable, suffering is optional. Pain is a part of life, both physical and existential pain, and this likely is always going to be the case. But we don't need to stay stuck in the suffering of our pain. And one amazing aspect of being a professional helper is that we have ample opportunities to help people address their pain and alleviate suffering. This is where the work of counselors, other mental health professionals, and really all allied healthcare professionals is so important in the arena of trauma. We have the ability to serve as agents of change, agents of transformation. By better understanding the complexity of trauma, counselors and other health and mental health care providers can assist clients and systems in meaningful transformation. Let's face it, trauma is ubiquitous among individuals and across societies worldwide. However, people have an incredible capacity for resilience. Although the helping professions have tended to regard trauma mostly from psychological and emotional perspectives, recent neurobiological research has provided better understandings of brain function before and during traumatic events, thus illuminating the important relationship between visceral experiences and the autonomic nervous system. Parallel to the exciting new developments in neuroscience, the public health sector, and by extension, the public mental health sector, have been instrumental in promoting a more systemic understanding of the impact of trauma. Our ongoing struggle with the COVID-19 pandemic may offer a perfect storm example of the intersection of personal, interpersonal, societal, and cross-cultural experiences of trauma that can be examined through an individual and societal public health lens. This webinar highlights and briefly examines these intersectional issues in terms of recent understandings of trauma and its multi-layered effects on individuals and societies. Most simply put, trauma is an emotional response to a terrible event. I think that this is a terrific beginning definition of trauma, and it's pretty straightforward. Trauma is an emotional response to a terrible event. The thing is, when we begin to unpack this definition a bit, we also begin to see that it becomes a bit more complicated. As soon as we say emotional response, we not only need to think about the person's psychosocial development and cultural context, but we need to think about neurobiology and how the brain processes and regulates our emotions. Traumatic events may include any of the following issues. This is not intended as an exhaustive list, but rather to illustrate the breadth of the typology along which traumatic incidences fall. And of course, each and every one of these situations might be experienced differently by different people. I'm not going to read this list to you. I know that you're all familiar with these types of trauma events. Trauma affects us on multiple levels, and these include personal, cognitively, affectively, existentially, spiritually, physical, biologically, and neurobiologically, relational, societal, and cultural levels. It's important when we're working with survivors to be attentive to the possibility of trauma at any of these levels and perhaps all of them. Psychological trauma is a subjective and relative phenomenon. Definitions vary depending on whether the focus is on DSM-5 diagnostic criteria, for example, post-traumatic stress disorder, lifespan stage, for example, children versus adult, or the context of the potentially traumatic event. Dr. Francine Shapiro has helped us to understand the variation in trauma impact through her concept of large T traumas and small t traumas. And of course, we need to bear in mind that one person's small t maybe someone else's large T. All of these definitions serve to illuminate that psychologically traumatic events demand extraordinary efforts to cope. Traumatic events destroy the survivor's fundamental assumptions about the safety of the world, which really is basic trust, the positive value of the self, and the meaningful order of creation, that is, our worldview and how we make meaning within that framework. It's difficult to overstate the existential impact that trauma can have on an individual and even on a community. I think that one of the most important steps that we can take with a survivor is helping them to establish a sense of safety before moving on to any other aspect of the trauma. So let's revisit models of human growth and development just briefly, and hang in with me. There's a method to my madness here. I realize that Maslow's hierarchy of needs is an old model and one with which most of you are familiar. But I think that it's important to reacquaint ourselves with Maslow's hierarchy in the context of discussing trauma, especially because counselors and other helpers have a tendency to jump into working with people at the esteem level. Just imagine this scenario for a moment. The school counselor is presenting a guidance lesson on the importance of self-esteem. Please don't get me wrong. It's important for children to develop a positive sense of self-esteem. But imagine the child who was up all night because of ongoing fighting between mom and her boyfriend that sometimes got physical as well as very loud. This child didn't have dinner last night and ran out of the house without breakfast. There's no way that the child can focus on a lesson about self-esteem. We need to make sure that this child's basic needs are being met, the lower rungs of the model, before even approaching the middle and upper rung issues. I'm also aware that this is a purely psychological and linear model. The information is necessary, but not sufficient to help us understand trauma. I want us to look just for a moment at this comparison of Freud, Erikson, and Piaget's stage theories table. We could spend hours talking about these major psychological theories in reference to trauma. And I know everyone loves to hate Freud, but as it turns out, we're discovering that some of Siggy's ideas actually have relevance. And Piaget certainly is important, especially to teachers in understanding cognitive and operational development. But I'd like to focus on Erikson's psychosocial theory of development for a moment. Erikson proposed 8 stages, in each of which a specific developmental task is supposed to be achieved, resolving any psychosocial conflicts that arise. If successful, the individual is ready to develop into the next stage. If not successful, the model identifies specific developmental failures that arise from not completing the task. Several decades ago, when I was trying to make sense out of helping traumatized clients years before the DSM-3 actually named PTSD in 1980, it jumped out at me that the issues listed as failures in completing the developmental tasks were important issues that emerged when my clients discussed their traumatic experiences. Mistrust, shame and doubt, guilt, inferiority, role confusion, and even a sense of stagnation or despair among older folks. And if we focus on those first couple of stages, the earlier stages, we start to see the implications of early childhood trauma that manifest as serious trust and shame issues when we work with adults with complex trauma. This begs the question of attachment, and I will expand on this in a moment. I just want to point out that these are also mostly psychological and linear models, and that they are stage dependent. but they begin to hint at the importance of biology, and Erickson starts to conceptualize the importance of a psychosocial framework. Again, this information is necessary but not sufficient in helping us to understand trauma. I think it's important to revisit attachment theory as a part of understanding the effects of trauma. Attachment was a concept originally proposed by the late John Bowlby in 1958. It is highly relevant to the discussion of trauma, particularly in association with early childhood trauma and its potential lifelong effects. The term has been used when referring to the emotionally close and important social relationships that people have with each other. Bowlby's work offered the basis for identifying 4 basic characteristics of attachment that have assisted professionals in understanding the importance of bonding in the relationship between a child and his or her caregiver. Having a safe haven, having a secure base, engaging in proximity maintenance, and showing separation distress. The aim of attachment theory was to explain how relationships form and the role that they play in the individual's development. Although Bowlby originally proposed attachment theory as a basis for understanding social relationships across the lifespan, much of the early work in this field concentrated on parent-child relationships, especially mother-infant dyads. The focus of the early attachment literature and research was to understand how the young child came to view the world as safe, stimulating, and a challenging place to live. Attachment theory suggests that significant social relationships provide the individual with a secure base from which to explore the world. With this secure base, the individual is motivated to seek out and investigate the challenges offered by the environment. In turn, this positive experience with the world helps the child to develop his or her confidence and abilities. It long has been thought that if attachment is seriously interrupted, as is often the case with early childhood trauma, significant developmental issues may emerge. Given recent neurobiological research regarding the effects of trauma on the brain, more is understood about the integrative effects of a particular individual's attachment and neurobiology. I think that Bronfenbrenner's bioecological model of human development remains relevant, and that having a biological perspective of trauma is really useful in understanding clients' lived experiences, especially across multiple dimensions of their lives. Uri Bronfenbrenner has offered an elegant model for understanding the comprehensive and reciprocal influences of multiple systems on human development. Simply put, ontogenic or individual development is nested within larger systems that affects the person's development. From proximal or closer to distal or at a greater distance, these systemic influences include the microsystem, which is the immediate environment, including the family, the mesosystem, inclusive of situations in which 2 or more microsystems come together to have some effect on the individual's life, the exosystem, which is the community and the neighborhood, the macrosystem, inclusive of broad cultural values and beliefs, and the chronosystem, denoting socio-historical time, as well as the real-time personal events and developmental transitions in an individual's life since birth. Environmental factors, along with genetic predispositions, influence the child, and continual reciprocal transactions within the environment or ecology determine risk and protective factors. After the initial development of his ecological model, Bronfenbrenner later renamed the model, changing it to the bioecological model, thus re-emphasizing interactions between heredity and environment. This is significant, particularly in light of the more recent neurobiological research concerning the physiological effects of trauma on the brain and other systems of the body. There's just so much going on in this model, and really important links to later information. So bear with me. This one is just a little bit long. Most contemporary theories of development have acknowledged the roles of both heredity and environment, and many have suggested the importance of systemic and transactional perspectives. The literature on developmental psychopathology has provided a developmental ecological framework for understanding the profound interplay between normal development and abnormal events, especially in the form of child maltreatment. It also has emphasized the role of attachment in children's lives, seeking to assess connections between the quality of attachment and the impact of maltreatment. This perspective has offered a baseline for comprehending the effects of chronic violence on children, and by extension, some of the trauma-related sequelae of adults who experience severe maltreatment in early childhood. Drawing from Bronfenbrenner's bioecological model, developmental psychopathology examines the risk factors as well as the compensatory or protective factors which exist across multiple and interactive environments in which we all live. The arrows in the figure represent the potential for both risk and protective factors across and within the systemic levels. The arrows also represent the reciprocity of the model. The environment has an impact on the individual, just as, in reciprocal fashion, the individual has an impact on the environment. Rather than being linear, as is the case with the previous models that we discussed, this model is both ecological and transactional, offering an avenue for understanding in a comprehensive way the influence of multiple factors at multiple levels on children's development. Such an articulation of the transactional nature of development is paramount to understanding the complex, sometimes paradoxical effects of maltreatment on children at multiple systemic levels. An understanding of the bioecological model, its transactional and systemic nature, and the role of attachment across the lifespan is an essential aspect of understanding the impact of trauma, allowing us to situate the lived experiences of traumatized persons within the time and space of a relevant ecology in order to understand the trauma event as well as personal meaning making about them. Polyvagal theory, which we will discuss briefly in a moment, is compatible with this ecological perspective as an extension of the biological dimension of the individual, seen as nested within the microsystem and other systemic levels of the bioecological model. And just as a really quick sidebar, it's important that we not acknowledge the temporal aspect of potentiating or risk factors and compensatory or protective factors. Either of these can exist in the environment as transient or enduring factors. It's essential to assess risk and protective factors when working with individuals and with communities experiencing trauma. Understanding the dynamics of the bioecological model begins to bring us to the cusp of seeing the interactions between personal and public health issues that relate to trauma. This brings us to the relevance of the Adverse Childhood Experiences Study, called the ACE study for short. The landmark study by Filiti and colleagues illuminated what many clinicians had been realizing about clients' trauma histories anecdotally long before the evidence was aggregated systematically. Fortunately, Falidi and his colleagues took the time and initiative to investigate what they also had been observing in clinical settings, that many individuals have endured adverse childhood experiences and that there are serious health consequences. The ACE study was undertaken from 1995 to 1997 by the Centers for Disease Control and Prevention, CDC, and Kaiser Permanente, a managed healthcare consortium. The investigation involved over 17,000 subjects, which is an unusually high number, thus suggesting that the results of the study are quite robust. ACEs can have a profound influence on future violence, both victimization and perpetration, as well as on the health and the potential opportunity over the lifespan. This makes adverse childhood experiences an important public health issue. According to a CDC website, ACEs have been linked to the following outcomes: risky health behaviors, chronic health conditions, low life potential, and early death. The greater the number of ACEs that a person has experienced, the higher the risk becomes for experiencing these outcomes. The pyramid on the screen represents health risks and social impairments across the lifespan that may result from the core ACE that forms the base of the pyramid. I think that it's important to note that the pyramid has had a recent facelift. The original ACE pyramid had the ACE at the bottom rung. The new iteration, based on increased research associated with the model, accounts for the important effects of historical trauma, how it may be embodied across generations, and the social context that exists before a child is even exposed to adverse childhood experiences. This important addition takes into account our more recent understandings of the neurobiology of trauma, how it affects and may alter the brain, even causing the epigenetic changes that we have observed among groups of people affected by historical trauma. Adverse childhood experiences are stressful or traumatic events, and a high ACE score is an indicator for high risk across the lifespan. Individuals who have experienced ACEs are likely to develop a wide range of health problems, with the prevalence of health problems being higher for those scoring a higher number of ACEs. The original ACE study identified the most common ACEs as physical, sexual, and emotional abuse, physical and emotional neglect, intimate partner violence, observing one's mother treated violently, substance misuse within the household, household mental illness, parental separation or divorce, and having an incarcerated household member. Clearly, there is a strong association between the health-related effects of ACEs and stress. And this illuminates how stress is implicated in the experience of trauma, certainly on the individual, but potentially also on families, communities, and societies. Better understandings of physiological and hormonal responses to stress, anxiety, and trauma have led to increased knowledge about how the brain is implicated in the effects of trauma. In comparison scans of a healthy brain and the brain of someone who has been abused, even a non-neurologist can spot the differences easily. Neuroscience research has helped us in cultivating a better apprehension of ways that the brain affects social relationships. Recent advances in neuroscience are helping us to understand why some people are so much more susceptible to developing symptoms of PTSD, while others remain so much more resilient. Okay, I don't want to get too geeky about the brain here, This and polyvagal theory are really much longer discussions, actually entire courses. But just to remind us of some parts of the brain relevant to trauma, let's note these three parts and their functions. The prefrontal cortex, which is considered the thinking center, the anterior cingulate cortex, which comprises the emotion regulation center, and the amygdala, which is the fear center. Generally, the prefrontal cortex, the center for thinking and logic, communicates well with the hippocampus, where memory is stored and emotions are regulated. But when someone experiences a traumatic event, communication between the prefrontal cortex, thinking and logic, and the hippocampus, memory and emotion regulation, becomes weak. This weak link strengthens the amygdala's response to turn on fight, flight, freeze, and stores the memories of the event. Remember, the amygdala is that little cave person residing in the brain, ready to push the panic button whenever we perceive danger. This brings us to polyvagal theory, perhaps one of the most intriguing and promising contributions to the field of traumatology in recent years. Polyvagal theory was developed and introduced by Professor Stephen Porges in 1994. Polyvagal theory relies on an understanding of the vagus nerve, and the functions and mechanisms of the vagus nerve have important implications for how humans respond to, experience, and process stress, anxiety, and trauma. Polyvagal theory has assisted clinicians in understanding the effects of trauma on the autonomic nervous system and its interactions with brain activity and the activity of other major organs in the body before, during, and after a traumatic event. In many ways, polyvagal theory offers a portal through which mental health clinicians who may not be brain experts have an avenue for better understanding the neurobiological perspective of trauma. The vagus nerve is the most important nerve that many people don't even know we have. The vagus nerve is one of the 12 pairs of cranial nerves located within the sensory somatic nervous system, and it has the longest nerve in the autonomic nervous system. The vagus nerve constitutes the 10th pair of cranial nerves. It serves as the main set of nerves in the parasympathetic nervous system, originating in the brainstem and traveling down the sides of the neck, across the chest, and down through the abdomen. The vagus nerve has important links to the brain, heart, lungs, and other major organs. The vagus nerve has a branch that connects inside the ear, thus filtering out background noises and making it easier to hear the human voice. The vagus nerve engages and regulates muscles in the face and head, resulting in a coupling between social engagement behaviors and bodily states, according to Porges. The vagus nerve affects the larynx through vocal tone and patterning. This is called prosody, and it helps humans to create sounds that can soothe others. I'll offer two brief illustrations, and both of them illuminate how modern science is helping us understand some of the ancient wisdom that's been passed down to us. Think about that sacred ancient syllable, Om. It vibrates in a way that activates sound, stimulates the nerve, and actually ends up soothing the brain. In another example, think about the calming sound made by a Tibetan singing bowl used in meditation, or the sound of an altar bell used in many religious ceremonies. Prior to conceptualizing polyvagal theory, the autonomic nervous system was viewed as having two major responses to trauma, those of the sympathetic nervous system and those of the parasympathetic nervous system. As just a refresher, we can go back to high school biology class and revisit the autonomic nervous system, or the ANS. The ANS is responsible for all of those biological processes that we don't even think about. For example, as I'm sitting here talking to you, I'm not thinking to myself that I need to breathe, and I'm not thinking about the fact that my heart keeps beating. Under normal circumstances, these processes just happen. So the sympathetic nervous system initiates the fight or flight response when we perceive danger in the environment. And it doesn't matter whether the threat is real or perceived. Our brains are hardwired to activate the response when we sense danger. The sympathetic nervous system increases muscle blood flow and tension, dilates pupils, accelerates heart rate and respiration, and increases perspiration and arterial blood pressure. The parasympathetic nervous system is the rest and digest system. It drives the freeze response that is part of that fight, flight, freeze response that is often discussed in traumatology. The parasympathetic nervous system conserves energy by slowing the heart rate, increasing intestinal and gland activity, and relaxing the sphincter muscles in the gastrointestinal tract. The vagus nerve interacts with the autonomic nervous system, but polyvagal theory has identified a third type of neural circuit response, the social engagement system, which helps us to navigate social relationships in the environment, including interpreting facial expressions and gestures of others. Polyvagal theory is so much more complex and elegant than we have time for today, so please understand that I'm not even close to giving you the Cliff Note version here. Basically, the vagus nerve has three neural circuits or functions: mobilization, social engagement, social communicative, and immobilization. Porges states that these three neural circuits form a phylogenetically ordered response hierarchy that regulates behavioral and physiological adaptation to safe, dangerous, and life-threatening environments. Obviously, polyvagal theory is a complex and elegant addition to our understanding of brain science and the impact of trauma. The major point here is that polyvagal theory helps us to understand the intersections of trauma and neurobiology, as well as the connections between personal and public health issues related to trauma. Polyvagal theory offers neurobiological explanations for earlier developmental theories, as well as echoing the centrality of the individual adverse childhood experiences and collective historical trauma to personal and public health issues. So all of this helps us to understand the effects of PTSD, which of course can be overwhelming, as we all know. But there's a little good news on the PTSD prevalence site. As ubiquitous as traumatic events are, and as much suffering as they cause, the prevalence rate and agreement of PTSD criteria, according to DSM-4 and 5 and ICD-10 and 11, are actually much lower. This is the opening where we know counselors and other helpers truly can help. We also need to take note of the remarkable capacity that human beings have for resilience. In the face of incredible traumatic experiences, people are able to tap into reservoirs of resilience, often making meaning out of trauma in ways that actually promote growth. And as mental health professionals, we have the tools to assist individuals and communities to build, reinforce, and restore resiliency. I truly believe that the human spirit is capable of extraordinary resilience. In fact, the research suggests that between 30 to 70% of individuals who experience trauma also report positive change and growth coming out of the traumatic experience. We can revisit Bronfenbrenner's elegant bioecological model to visualize how trauma affects us systemically. Exposure to traumatic experiences can affect us individually in many ways, both in the short and long term. But trauma reverberates systemically. It can manifest in both personal and public health issues. Remember the ACE pyramid that we looked at earlier. The results of the ACE study offer an excellent example of how trauma becomes a public health issue. The costs of adverse childhood experiences have been enormous. Of course, as helpers, we've primarily been focused on the more personal costs. But when we think about translating the impact of adverse childhood experiences into the fiduciary effects of these healthcare costs on the society, research has shown that annual healthcare costs attributable to ACEs total about $748 billion. That's billion with a B. If we were to address and prevent ACEs, such efforts could save the federal government about $217 billion each year. Again, that's billion with a B. Addressing ACEs systemically, along with related prevention efforts, requires the use of well-calibrated public health strategies. In this discussion, we've seen hints from classic human development models that human interactions can have an impact on health. We have touched on the synergistic intersections among individuals and their lived experiences with proximal and distal environmental influences, including the behavior of other human beings. We have noted the stark reality of how being born into a low resource environment already affected by historical trauma, along with other types of adverse childhood experiences, can lead to public health problems across the lifespan and even to premature death. In addition to this stark reality, we also are at a unique juncture in the evolution of humanity. We are experiencing an unprecedented confluence of complex crises that have given rise globally to human-made and natural disasters and that have led to mass casualties. One example is Syria, where anthropogenic climate change caused migration and conflict, and which ultimately led to horrific human trauma and affected the public health of entire geographical regions. Another example is the geopolitical violence being perpetrated against Ukraine. The atrocities are not only causing trauma and extreme suffering for the people of Ukraine, but the warfare is affecting the public health of Ukrainians and many others in the region, as well as threatening the worldwide food supply as Ukraine provides wheat for much of the world. The warfare also threatens to affect the global economy in disastrous ways, including public health systems, which in turn stand to have the worst effects on vulnerable and poor populations. And of course, I would be remiss not to mention the devastating global effects of the current COVID-19 pandemic, causing trauma and affecting healthcare both personally and collectively. And there's a situation going on in the Republic of South Africa right now on the East Coast. The city of Durban is, large parts of it are being washed away because of what is probably climate change related bad weather. As we have been discussing, trauma is not a simple event. Rather, it is a complex issue, often intersecting with other stressors, crises, traumas, and disasters. We can think of how all of the associated constructs begin to frame a scaffold for understanding the complexity and confluence of these lived experiences. In the new edition of my trauma counseling book, I have written about what I've been calling the trauma scaffold, borrowing a learning concept from Lev Vygotsky's psychological development theory. I am suggesting that we need to have a foundational trauma scaffold, a conceptual version of a physical scaffolding structure upon which to visualize and understand the profound effects of traumatic experiences. First, such a trauma scaffold enables us to see readily and to understand clearly the connections between the personal and the systemic impacts of trauma. Second, the trauma scaffold assists us in understanding and building upon distinct and yet interconnected concepts like attachment and shame, as well as firmly preparing and supporting us for the nuanced comprehensions of more complex issues of trauma. I believe that a foundational trauma scaffold, inclusive of the spectrum of traumatic experiences and their impacts, is essential in helping us to help survivors in their recovery and resilience building efforts. Such a trauma scaffold also can be useful to counselor educators and other pre-service educators in understanding issues of trauma in their complexity in order to assist counselors in training to appreciate the many various threads that constitute the trauma scaffold, including stress, crisis, attachment issues, shame, guilt, bioecological development, neurobiology, disaster situations, and the complexity of many, sometimes intersecting traumatic events. Trauma is a personal and public health issue. The literature points to the pervasiveness of trauma worldwide and addresses the substantial cost of trauma, both on personal and societal levels. Trauma has become a global public health issue. We no longer can ignore the intersections of trauma and personal and public health issues. As important as a focus on individual recovery and healing processes are, we also must attend to the necessity of designing and developing prevention-based interventions. The delivery of trauma-informed prevention services is essential across all of the healthcare disciplines. Trauma truly is both a personal and a public health issue. Prevention becomes essential. We have the tools to respond to people experiencing trauma and to assist in their recovery and healing. We have the mechanisms for building more resilient communities. We need to adopt strategies to mitigate the effects of trauma at both personal and public health levels.
Thank you, Dr. Lopez-Levers. My name is Rhonda Dearborn, everyone. I'm the acquisitions editor that works with Lisa and our authors on the counseling publishing program here at Springer Publishing Company. Lisa, if you can advance to the next slide before we get into Q&A. I just want to underscore that Lisa's second edition of Trauma Counseling, Theories and Interventions for Managing Trauma, Stress, Crisis, and Disaster is now available. There are some links here and a code. That was the special offer that Lee had referenced earlier in the presentation. 30% plus free shipping with this code that you see here at the bottom of the screen. If you are a faculty member, a professor, and you are interested in adopting the second edition for your course, please contact our sales representative, Jill Legg, and you can see her email address, jlegg@springerpub.com. If you're interested in bulk sales or continuing education, use of the book for professional development or for an association, you can contact Lee. Lee was the individual who opened up the presentation and talked a little bit about what you could expect in the presentation, that it was being recorded and being disseminated. Lee is our Director of Special Sales and New Business Development, and his email address is there on the screen. I'm going to again just reiterate for those who joined us a little bit late that this presentation is being recorded and that it will be disseminated via email to not just the folks who are live today on the call, but also those who registered and didn't have an opportunity to join us. So a lot of folks will be able to see and enjoy this presentation and learn from it. In addition, Dr. Lopez-Lever's presentation deck will also be disseminated as a PDF. So I just wanted to reiterate that. And now, Lisa, I have a couple of questions for you. One of those is, can your book be used across a curriculum and not just in one course, hypothetically, a trauma counseling course?
This is an excellent question. And if someone were to charge me right this minute with developing a new counseling program, I would have probably 2 or 3 courses devoted to trauma, stress, crisis, disaster issues. And in that scenario, I believe very much that this book would be useful across the curriculum, and then specifically in multiple courses. And there is an instructor's manual for people who end up adopting this, that is just chock full of information, extra readings, exercises, videos, etc. And I think that by adapting additional readings and other instructional materials along with the various chapters in this book, I think it very easily could lend itself to, 1, being used across the curriculum, 2, being used for 2, possibly 3 trauma-related courses. And in addition, with just a few extra readings, I think that this book could be very useful in public health programs, with a course on trauma-informed public health issues, as well as, I would love to see medical schools have some kind of course on trauma-informed healthcare practices. Man, some of the physicians I've seen could really benefit from a little bit of, you don't want to talk to your patients who have been traumatized that way kind of information. So I think that this particular volume could be useful in a medical school context and could be useful in a public health degree context, along with our counseling programs that really need to be focusing much more on trauma, crisis, and disaster issues.
Thank you, Lisa. Thank you.
Mm-hmm.
There's another question. How much polyvagal coverage, theory coverage is in your book?
In the first 3 chapters, I really kind of try to set up sort of the argument that I made in this presentation. Hey, folks, we can no longer afford to look at trauma as a simple event. We've got to be thinking of all these strands. So in the context of pulling the strands together, I I pull in bits of polyvagal theory. I believe that it's in chapter 2 where I have a section really focused on that. Some allusions to it in chapter 3. And then chapter 4 focuses on recent neuroscience as well as recent pharmacology. In addition to that, I asked all of the authors, and I'm involved in a number of the chapters, but I asked all of the authors to make sure that updates to the information for each chapter included relevant information to neurobiology and polyvagal theory. So I want to answer your question. Honestly, the book has a lot of that information parsed throughout it, but there's not a whole chapter devoted
Right.
to polyvagal theory.
That's one of the things I think we've told people is how that neuroscience is an emphasis, especially in the second edition.
Yeah.
So yeah, thank you, Lisa. Thank you so much, everyone. I want to thank all the attendees for spending so much of your afternoon with us. We hope that you enjoyed it as much as we did and got so much out of it. I also want to thank all the internal folks here at Springer who helped put this together. And most importantly, I want to thank Dr. Lopez Levers for putting this presentation together today and spending time with us this afternoon. Thank you all so much, and have a great rest of your day.